I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti, I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
49-year-old female, never smoker, with a history of papillary thyroid cancer, status post-resection and radioactive iodine in 2011. Now with a recently resected Masaoka stage 2A WHO type B2 thymoma with close margins. The tumor measured 4.5 by 3.5 by 1.7 in anterior superior mediastinum with microscopic capsular invasion. And the question really here is, post-operatively, given the close margins, what would we as a group recommend? So just some patient pertinent positive symptoms. So the patient presented with cough, shortness of breath, anorexia, and a 10-pound weight loss after a right pneumothorax following a CT-guided biopsy of the mediastinal mass. The pertinent negatives: patient prior to the biopsy was asymptomatic with no neurological symptoms, and certainly looking out for myasthenia-like symptoms with patients with thymoma, and has a preserved performance status. Medical history consistent with a papillary thyroid cancer, hypothyroidism after thyroidectomy and radioactive iodine, and bilateral breast augmentation. Social history: never smoker, occasional a glass of wine, denies any illicit drug use, and family history consistent with the father and maternal grandfather had prostate cancer, but no other family history of malignancy. So, maybe we can turn first to Dr. Ginsberg just to tell us kind of what we're seeing here on this PET, and then we can kind of go over what happened next.
The PET images demonstrate an FDG-avid anterior mediastinal mass, which on the top image is an axial image, and on the bottom it's a coronal image. It's a well-delineated mass with an SUV of 4.1 and had increased from previous measurements.
Great, thank you, Dr. Ginsberg. So the patient has a CT-guided fine needle aspiration that revealed atypical cells, but a little limited sampling, and then has a VATS with the assumption that this may be a thymoma. And so the VATS is performed, and the pathology is consistent with a 4.5 by 3.5 by 1.7 centimeter type B2 thymoma with negative margins, but it's 0.1 millimeters is the closest margin. The final stage is a T1NX, a pathological T1NX with microscopic capsular invasion. The question here is, with a close margin in a very young, fit patient, is there a role for adjuvant treatment? Maybe I can back up and just discuss with Dr. Lanuti, the approach here for an anterior mediastinal mass like this.
Yeah, so with suspicious FDG-avid lesions, one is we don't often use PET scan to interrogate an anterior mediastinal mass, but it's acceptable. In this case, a fine needle aspirate would be something that you could do. We would often move to a core, despite the fact that there's this notion that you could get dissemination. The core needle biopsies, in our experience, have not disseminated, so we would often recommend that for diagnosis. Using a VATS for diagnosis is not really recommended, hence because you don't know what it is, and if you violate the capsule, you put the patient at risk for ipsilateral drop metastases in the pleural space. So if you knew that it was a thymic neoplasm, you have to be a pretty skilled person with VATS to do a good job with complete resection. We would often advocate for either a robotic type approach to this or the traditional partial to full sternotomy for complete resection. So this idea that you have a close margin, the problem is you don't know where the close margin is. And for surgeons, that's the important part. And so, for this concept of, is there any role for re-resection? The answer is no, because you don't know where you're going. And already there is the possibility that this patient, could be at risk for a drop metastasis if this was a so-called a careless or sloppy surgery.
So all good points. Can you explain to the non-pathologist and the non-surgeons about this whole idea of there's no tumor on ink? What does that mean? There are close margins, but there's no tumor. What does it mean if there's tumor on ink?
Yeah, tumor on ink is, the specimen's removed from the field, and it's supposed to be oriented by the surgeon and then taken to the pathologist for where they ink the entire exterior surface. And so we're looking for is a small membrane or some barrier between ink and tumor. If there's ink, or if there's tumor at the ink, that would suggest that there could be tumor left behind in the patient. And you would want to know that, and you would want to know where your close margin is in case you have to consider a radiation option. Oftentimes we see this in the region of the phrenic nerve, where we're deciding should we resect the nerve or not. And if we leave a positive margin there, we would radiate.
So in this case, it's a close margin. There's no tumor on ink. I think you've already stated you would not go back and re-resect. Dr. Curran, this patient's in your office. Your thoughts on whether the patient should get radiation or not adjuvantly?
Yeah, so thank you. Yeah, interesting story. So I think that as all you know, there haven't been a lot of prospective trials for how to manage such a patient. So most of the data is in comparing outcome with or without radiation. About 8,000 years ago, I wrote a paper that looked at the series from University of Pennsylvania, Virginia Commonwealth, and Fox Chase. And we were able to identify patients who did not have gross extracapsular extension, had exactly this category. And those patients, in over a few decades of care, even without radiation, had a very low local failure rate. If you had macroscopic or transcapsular transgression of the tumor, with or without positive margin, there was a high local failure rate without radiation. So this is a patient, unless the surgeon told me otherwise, that he or she was particularly concerned, as Dr. Lanuti said, about a particular area and could really identify it, could probably be okay with close follow-up, given that you have a grossly negative margin, and the capsule penetration looked microscopic at most. But again, I agree with the point that there may be an alternative surgical approach which would have lowered the risk of there being a close margin.
Great. And Dr. Govindan, just final parting shots here before we move on the role or lack thereof of any adjuvant systemic treatment for this patient.
This is one of those clear-cut situations that there's clearly no role for any adjuvant cytotoxic chemotherapy in the situation. I completely agree with Dr. Curran's assessment. We would simply follow these patients.
So Dr. Curran and Dr. Govindan, we were going to move on to the next case, but you both said you'd follow the patient closely. What does that mean? Does that mean, Kat, I know we don't have a lot of evidence-based data, even in non-small cell lung cancer, how frequently the imaging should be and with what would be the recommendation for this patient for the first year or two in terms of what type of scan and what interval would you choose? I know not a lot of data here. Dr. Curran, your thoughts, and maybe Dr. Govindan can just chime in.
Maybe every 6 months for a year and a half, and then annually with high quality chest CT. I mean, you really want to look at, as Dr. Lanuti said, the risk of pleural drop metastases. It's also worth pointing out, when I did that series review a while ago, some of the quote unquote bad actors that were classified by good pathology departments as thymomas turned out to be thymic carcinoma. So that's very different. Obviously, the recommendation would be different.
Okay. Any other thoughts, Dr. Govindan?
I
Similar?
agree with Dr. Karan. The only thing I want to point out to our medical oncologists is that unlike lung cancer, thymoma can recur many, many years later. And that's something worth keeping in mind. So I'm very curious to hear others' thoughts as well on this. But traditional lung cancer or follow-up precipitously drops out after 4 or 5 years. And here we would continue to extend beyond around 10 years at least.
Yeah, I would concur with that. I'm just laying in my own opinion here briefly. I think we see a little bit difference after 5 years between non-small cell and these types of tumors. So I would extend that imaging out. So just to summarize this case, I think we all agree, one, that no re-resection should be considered currently. Two, that adjuvant radiation we should probably hold off on any adjuvant radiation. Three, there's no role for systemic treatment at this time. And then finally, there should be some sort of follow-up every 6 months, potentially for the first 1.5 to 2 years, with longitudinal follow-up that may extend beyond 5 years. Is that a reasonable kind of take home from this case? Great. Okay.
Dr. Levy, I just wanted to mention one more thing that I think is often underutilized. That is, you could alternate with MRI chest for these patients, particularly if they're young and you're going to follow them out 10 years. I think that's something that we've adopted, particularly for the young patients, given the longitudinal follow-up.
Great.